out-of-hours care. My name is Hilde Philips, but I'm not the only one who's working on the iCAREdata project. We will see it in a few minutes on the slides, who is involved in the whole project. So we have a scientific database, and it's now the perfect moment to present it to you because now it's operational since about 2 years now. So we have done some validation tests, and that's why we are here now. For those who don't know where Belgium is, but I guess everybody knows it, we're quite in the middle of Europe. And Belgium is a kind of special country because we have two parts in the country. We have in the northern part of the Dutch-speaking part, which we come from, and in the southern part, the French-speaking part of Belgium, which makes it a quite special country. So that's what you see, the Flemish region and the Walloon region. And we come from the northern part, which is Antwerp, which is in the middle of the northern region, just against towards the Netherlands. Okay, Antwerp is a very nice city, you all know that. We have some old buildings, we have some new buildings, they are quite beautiful. And also our university has some old buildings and new buildings. So if you pass by, please visit us. Okay, now, iCAREdata stuff now. So you see a whole bunch of people who is working on this project and has worked on it. You don't have to read all the names, of course, but it is a mixture of different kinds of people. There are researchers, ICTers, but also general practitioners, emergency physicians, pharmacists, and that's the strong thing that is iCAREdata about. It is multidisciplinary, and that is paying off now. iCAREdata stands for Improving Care and Research Electronic Data Trust Antwerp, and it is funded by the FWO, which is the Research Foundation of Flanders. So why did we do it? Huh? You can ask, how do you come on the idea to have a research database on out-of-hours care? Well, we know all, I think, that measuring is knowing. It's very important in medicine and in other things as well. We more and more evolve towards data-driven decision-making, which we heard about in the former presentations as well. But we want to optimize care, and we want to do it in daily care for our patients as a GP, but we also want to do it out of hours, which is a large part of the week. In fact, 2/3 of the week are out of hours, or in some countries even more than that. We cannot optimize care by organizing it in a different way. We can also improve the quality of care. We can improve the sustainability of care because we are with less GPs in Belgium as well, and it's evolving towards being decreasing still. And also we want to benchmark different services towards each other. So we need valid data, and we can use it on a micro, meso, and macro level. But how did we do that? Well, we chose to use routine data, which are registered during out of hours in Belgium quite good, better in fact than in daily care. And so we also strive for the FAIR principle of data. So data have to be findable. You have to find a database to use it. That's important. They have to be accessible as well. They have to be interoperable so that different researchers with different tools can use the database, and it has to be reusable. That's the most important thing. That's why we are here, that you all start to use the database if you need it, of course. To have data is not enough, you have to use it as well. So we want an optimal reuse of it, and we have a state-of-the-art research database which complies with the legal aspects, with ethical aspects as well. So what did we do? We started off in 2014. We are financed by the FWO, as I mentioned before, and we have different partners. We chose to have different partners because it is important in out-of-hours care to have the trajectory of the patient which comes to the out-of-office service of the GP on a Saturday morning, for instance, Then in the afternoon, he goes to the pharmacist to have his medication. But on Sunday, there is another problem, and he goes to the emergency department. It is a trajectory that the patient might follow. So that is exactly what iCAREdata can do. We can see what a patient does, of course, not the individual patient himself, but we can see the trajectory. And that's the reason why we had those different partners from the beginning. We started off with research on out-of-hours care in general practice in 2003, and that was the moment in Belgium when we started off with general practice cooperatives, which were implemented at that time because we had a decreasing number of GPs. It wasn't possible anymore to have the continuity of care we wanted to have. And there was also in large cities, there was a safety problem, and that was the reason that we all made it in a general practice cooperative together, that all GPs could work there, and we had one central place in a city where people could go to during out of hours. It is a bit the same as the emergency department of a hospital, which is also on the same place. It doesn't change every weekend. And before we had general practice cooperatives in Belgium, the general practitioner who was on call changed every weekend or even every 24 hours. So patients had to go look for the doctor, and that was difficult. So now the movement has started in 2003. And I think now about 60 or 80% of Flanders is covered by general practice cooperatives. But doing research, it was very, very difficult to get data that were valid and that were reliable. We had to ask some doctors at that time to make some extra registrations on paper, etc. And so it was very difficult. They forgot it, it got lost, etc. So that's why we thought, an own research database, that was our dream, and okay, we have it now. But it gives more opportunities for research topics as an academic center, but it can always also be used by others. It gives us a possibility to respond to research questions from our partners as well. We often get questions to have a look at the number of home visits and how it evolves during the years. We also can optimize the quality of data because we all know that GPs not always are very correct in registrations and working with a computer. But we do help them out to improve that, and we help them, for instance, to use ICPC classification systems, etc. They don't like it, but when you can do it in a group together with other GPs who work in the same general practice cooperative, then it works out. So it can change the mentality as well. So the multidisciplinary focus was there from the beginning and is very important, and we were very happy to have those partners also. The main aim was to have a research database on out-of-hours care with multidisciplinary data which could be linked to each other. Remember the trajectory of the patient who goes to the GPC, to the pharmacy, and then later on to the emergency department, and with the legal ethical and privacy issues that are in place. At this moment, we have about 14 general practice cooperatives who regularly give data, and they give it on a weekly basis. So we have a whole lot of data coming in every weekend. It is about 2,800, 3,000 contacts that come every weekend. We now have 2 emergency departments who deliver on a weekly basis data to the database, and the 3rd one is coming, maybe as we speak now even. And we do have 80% of all pharmacists of Antwerp, which we have to broaden to other regions of Flanders as well. So by the end of 2019, we will cover about 2 million citizens by using the data of the general practice cooperatives. It is a research database. We are researchers and we are GPs, so I want to give you some idea of what we already did and what is ongoing in research at this moment. We have that thing called telephone triage 1733, which was started off by the Belgian government in, I think, 2005, meaning that there had to be a telephone number for non-urgent calls during out-of-hours care, and that number should be 1733. And we did the evaluation of the safety and the efficiency of these telephone triage systems, and that was the first research that we did on the database, just to look whether patients who are triaged, whether they do or do not make another choice, and whether the choice that is made is better than the choice that they would have made without triage. So that was the first large research project we did. We also just finished a very small study about overprescribing ocular corticosteroids. In out-of-hours primary care, we see that GPs prescribe it a lot of times for different things, and we just don't know why they do it, because there are not that much indications to do that. So we studied it, and it is quite finished. It will be hopefully published in a few weeks' time. One of the ongoing studies is a PhD study of Annelies Colliers, which is a participatory action research project. She uses that methodology, but she's asking GPs what might help them to change their prescription habits in the prescriptions of antibiotics for respiratory tract infections. Then we have another triage trial, which started off the beginning of this year, which is evaluating physical triage on emergency departments and whether patients see it as an option to go to the general practice cooperative instead of the emergency department when somebody has triaged them towards the GP. We also have some master and after master theses that are ongoing. We have a cooperation with Nivel in the Netherlands, which do almost the same thing as we do, only we have data on a weekly basis, and they have to wait a few months before they have data, but they do kind of the same thing. We are also a founding partner of the Euronet network, which maybe is known by some of you, which is a research network of 13 or 14 countries in Europe of researchers doing research on out-of-hours care. So we have weekly results on our website, and I will show it just to finish this presentation, why you can use it, whether you have some new ideas to put on. It is in Dutch and in English, so so you can look around when you have some time during the weekend or something. It is very interesting. At least that's my idea. It is a bit slow. Yes. For instance, this one, this is on a monthly basis that we have here the top 10 of diagnoses which are used in the general practice cooperatives. And a bit lower, you can choose your iCPC chapter yourself. If somebody wants to know something, just yell something. I will do the respiratory. Yeah? So it is a bit slow now. Yeah. Okay, there we go. Let's say we often see, and then you will get an idea of how many times this diagnosis was okay, there we go. So this is one of the examples of things that you can find on the websites. And you see how it evolves during the years and the months, the respiratory tract infections, for instance. Okay, when we have a look, we also have some other things. One of the things, of course, that we follow is the medication that is prescribed in the general practice cooperatives. For those who were wondering whether there are already data of the emergency departments, the answer is no. And the reason for that is that you saw that we only have 2 emergency departments at this moment. So the risk of identification of one of both emergency departments is still too large. So we wait until we have 4 or 5 of them, and then we will have aggregated data of emergency departments as well. So this is what general practitioners are prescribing in the month September, the last month. You see that ibuprofen is one of the most prescribed drugs in general practice during out of hours. Then we have amoxicillin, which is a topic for research. Why is it prescribed and for who? Then I will finish with the facts and figures. You also see that at the right side, there is a login. That's for the partners who want to have their own data. Every general practice cooperative can look at their own data just to do the benchmarking against the other GPC. You see how the number of patients that visit the GPC evolves during the day. The yellow line is the Sunday, the blue line is Saturday, and it's almost the same. So you see that most people come about 10 o'clock a.m., between 10 and 12 a.m. And that is one thing that you see in a lot of countries. It's quite the same thing in all countries. And it's also quite the same thing when we have a look at the numbers of the emergency departments. So that kind of stuff you can find on the website. I will close this now. So if you have suggestions, you can always mail us on iCAREdata@uantwerpen.be. So if there are any questions, I'll be glad to answer them.